Hello, my friends. How are you? We're here in Lizland where Hobby Lobby threw up. And I'm here with Dr. Matthew Weiner.
Hi, how are you?
Good, good. So, let you guys, I have the chat open. Let me know if you're here. I know this isn't the best time for people to join live because you may be at work, but if you're here and you have questions, I've got the chat open. So you can comment there, or if you're having trouble accessing, you can message me on Facebook or Instagram or something like that. All right. So we talked last time, probably about 2 years ago, I think.
Yeah.
And I was telling you beforehand, okay, I weigh 15 pounds more than I did then. And you uh, moved to a place probably as different as you could from where
I
you were
guess.
last time we talked.
Yeah.
So you're,
Yeah. So now I'm in Arizona. I'm in Tucson, Arizona. My wife and I kind of woke up one morning and, we loved living in Michigan and we're really happy. But we kind of turned to ourselves and said, is this the very best place we could be raising our children? Is this where we want to live for the rest of our lives? And we both kind of thought, it would be really exciting to live somewhere else. And it was kind of just a pie in the sky thought. And she said, why don't you submit your resume? And, I have everything kind of all in my Google Drive. And for me to submit a resume takes literally about 90 seconds. So I just kind of submitted my resume to a few places and thought, okay, we'll see what happens. And I was contacted by actually a guy who I knew in college, who has a very successful, huge practice in Tucson, said, I'm desperate need of another surgeon. And, it was kind of an offer I couldn't refuse. And we came down and just saw the beauty of Tucson. I mean, for someone who's never been, if you've never been to the Sonoran Desert, you are really missing out on one of the most beautiful places in the country. I mean, the mountains, the backdrop of the mountains, the sunsets here are just incredible. And you get that every single night. It's always sunny. It's a little warm now, but to be honest with you, it's not as bad as people think.
it's a dry heat,
So
right?
yeah, it's a dry heat. It
That's
really,
what they say.
I was in New York City this past weekend and it was so muggy, but it was 75, to me it was less comfortable than when it's 105 in Tucson. So, but anyway, so we're super happy here. Actually, it's been a very soft landing for us. My practice is kind of, is already growing very quickly. So we're really excited.
Well, that's awesome, and I'm glad to have
Yeah.
you closer to this side of the world in case I ever need it. Um, so I am, for those of you who don't know me, I'm 5 years post-op vertical sleeve gastrectomy. My starting weight was 402 pounds. The lowest I got, which was probably 18 months to 2 years post-op, was 198 pounds. So I basically lost half my body weight,
Yeah.
and I'm up from that. And then I sort of stayed around 207 for about 2 years. And now I'm up about 15 pounds more than that. So, and I find that with a lot of people who are in my sort of weight loss surgery class, regain and revision are sort of the topics of the week, month, year, and probably for the rest of our lives,
Yeah.
honestly. And I want to tell you guys, I put a link to Dr. Weiner's channel in this video, but I hadn't watched a lot of your videos in a while. You have the best educational videos that are concise and complete on all the different topics that are important around weight loss surgery than I've seen anyone else do. So you guys should definitely check that. Should check out his channel where he goes more in depth, but succinctly into some of these issues, which I find wonderful. So one of the first things I want to touch on is, what are the factors that sort of contribute to how much weight you're going to lose originally after weight loss surgery?
So, I mean, originally, the number one single most important determinant of how much weight you will lose after surgery is your genetics. And we haven't figured out which genes or even how to predict who is going to be successful or not. When I work with weight loss surgery patients, prospective weight loss surgery patients, I always ask them, do you have a first degree relative, a parent, child, or sibling who's had weight loss surgery? And if so, how'd they do? Chances are you'll do around the same. And when we look at predictive tools for weight loss after surgery, a your familial relations, if they've had surgery, are probably the best indicator we have. I think second to genetics would be age. Young people lose a lot more weight than older people. And that's just kind of a basic fact. After that, things like if you're a diabetic, that tends to limit your weight loss. If you're on mood stabilizer medications for bipolar disease, that tends to limit your weight loss. There's a few ethnic groups that may lose more or less weight than others, but those are actually very minor factors. Those are 5-10 pounds, where age and genetics are kind of more 20, 30, 40 pounds. Those are the two primary factors. A lot of people think how well I eat or how much I exercise is what's going to determine how much weight you're going to lose. I'm not so sure that's true. I think it matters, but not a huge amount. A lot of people also think once I hit that lowest point, then I can just exercise and eat right and I'll lose more. And oftentimes that lowest number you reach after surgery is kind of a floor that you just can't get below.
Right. So, and I just think it's important to say that because I also like to focus a lot. And when I talk to people about the mental aspect of this and the emotional aspect, and I think so many people who don't lose as much weight feel like they have, failed their surgery. Yeah. So I just think it's important to put out there that it's not all about that. So those factors, are more, that's like the first couple of years, right? So yeah. The genetics, that's the first couple of years. And then what happens?
So, and then the question is, you can't modify your genetics, right? You are who you are DNA wise. You can modify your lifestyle. And so after you've kind of reached that lowest weight, and sleeve patients kind of get to stay there comfortably without too much difficulty for usually around 2, maybe 3 years. Gastric bypass patients, often 3, 4, even 5 years, or often lifetime for gastric bypass patients where they can really maintain at that lowest weight comfortably. And then after that, it really starts to transition to being more lifestyle driven. People who've had a good genetic response tend to be a little more resistant. They're going to get a little more of a cushion in terms of their lifestyle factors, where if they're not perfect, they still may be able to modify that, maintain that weight. Patients who haven't lost as much weight tend to be more susceptible to weight regain. But at that point, the ball is to some degree in your court as a weight loss surgery patient. Now, that doesn't mean if you start to gain weight that it's all your fault, because it may require really, really rigorous lifestyle changes. Something like my Pound to Cure program, followed to the T perfectly, which is not easy to do. I have a lot of patients who've managed to do it, but I can tell you it's not easy to do. And even, I don't follow it 100%. So yeah, it's hard. I mean, I'm not going to lie to you, but I think it's important for us to kind of set the standard. And if that's what it takes for you to maintain your weight, I mean, that's a Herculean task to some degree. And so I think if you can't do that, I wouldn't be so critical of yourself.
I just want to mention the people who have popped in on chat. Carol, Susie, Schwig, who has a question. And this is, my situation too, is she's been going through menopause, and does that have a contributing factor as well?
For sure.
Yeah. And Carla Carlson is also here. So I just want to recognize those people. So when I reached out to you and I said, what I thought we could talk about was regain and revision, because it's very, it's what everybody's talking about and everybody that I know is sort of dealing with. And your response was, yeah, that's not surprising considering so many sleeps are being done. So I was like, oh, so tell me your thoughts about that.
Well, I mean, I think the first thing is that you have to look at obesity as a chronic disease. And, you'll have states of managing it better or worse throughout your life. And each treatment we have, and really weight loss surgery, I think is best viewed more as a medical treatment as opposed to some kind of anatomical change that permanently adjusts your eating. Anyone who's, more than 6 months out can attest to the fact that your experience early on after the surgery is very different from what your experience is now. The anatomy is really the same, and there's all this talk about stretching things out, but that doesn't really line up with success or with eating behaviors or satiety or anything like that. So, we have to recognize these are medical therapies, and medical therapies work to some degree. They often don't treat the problem fully, and they have varying lengths of time that they're effective for. And sleeves, while they're fantastic, and I do a lot of sleeves. I mean, don't get me wrong. It's not like I don't believe in the sleeve or anything like that. Half my practice is sleeves. They are, of the two surgeries that we offer, sleeves offer less weight loss and higher rates of weight regain. That's just inherent to it. Plus, we're starting to find out that there's, a fairly significant percentage of patients who develop chronic acid reflux, which can be mildly annoying all the way to, terribly debilitating.
I think you cut out just a little bit. Were you talking about reflux or something else?
Reflux, yes. So after a sleeve, you can see higher rates of reflux, and that can be very debilitating.
So I have a friend specifically who, her reflux and I guess gastroparesis is, really, really, really debilitating to her post sleeve, and that's and I don't know if you have anything to say about this, but I'm going to ask it anyway, because I know she would kill me if I had you on here and I didn't ask this, is, the insurance that she has now doesn't cover bariatric surgery. So she can't go back to her bariatrics surgeon about this. And she's gone to the gastroenterologist. They've done all the things. Do you have any thoughts on how to get, and you may not, any thoughts on how to get this covered if your insurance doesn't cover bariatrics?
So if your insurance doesn't cover bariatric surgery, it will often still cover treatment of complications. Gastroparesis, chronic acid reflux are complications. If they are untreated and they are severe, which it sounds like this is, then they can lead to a condition called Barrett's esophagus and ultimately esophageal cancer. So this is not a benign condition, and a well-worded letter and documentation of the patient's problem can convince insurance companies we are not treating obesity here. What they really have an exclusion for is surgical treatment of obesity. They don't necessarily have an exclusion. In fact, it's very unlikely they have an exclusion for any complications related to bariatric surgery in the past. That's usually not part of the policy, or for the treatment of gastroparesis and gastroesophageal reflux disease. When I see patients like these, I don't talk to them about their weight, because quite frankly, the treatment, which would be revision from a sleeve to a gastric bypass, offers a very modest weight loss. And really, that surgery for someone to lose 20 to 40 pounds, in my mind, is not really worth it as a revision for weight loss. So I think what I would encourage your friend to do is to, first of all, to find a bariatric surgeon well-versed. I don't know if they're in California, but Tucson's not that far away. Tennessee.
So she has less options.
So there's a guy in Tennessee at Vanderbilt named Wayne English, who's awesome.
Okay.
And he's part of university. Sometimes they can be tricky, but the key is to really approach this as a complication, and the surgery is treatment of gastroesophageal reflux disease and gastroparesis, not treatment of obesity.
Right. And I think it's so, and I've only learned this as she's been struggling with this, what the impact of this reflux can be long-term, like you're talking about.
Debilitating.
People should really, and of course, now that we've been talking about a lot, I'm starting to feel reflux, which I never felt before. I can get sort of in my head, but it's nowhere near as debilitating. But it's something that you need to take seriously if it's a constant and persistent problem. Okay, well, so since we touched on revision, let's talk about that just a little bit. So that's what you said has sort of been my perspective too, is because I would be happy to be at my lowest weight, which was like 198, which is still technically overweight, whatever, but I work out a lot. I have a lot of muscle mass. I'm happy with how I look there. But when it started to climb, I went back to my surgeon who when I was 400 pounds, most people at 400 pounds, they'll recommend RNY.
For sure.
not the sleeve. And he had said, you don't have any medical complications. Let's do the sleeve. And then you can come, if it doesn't, you know, if you don't get to where you want to be. And I had great success. I mean, 200 pounds with a sleeve.
You had amazing success.
At 48.
Typical success.
Yeah,
honestly,
it's pretty good.
Yeah.
So, but then I went back, and because I hadn't been in the 2 years in between where I got to my lowest, they're like, no way would we consider revision. You've maintained your weight 3 years post-op because it was the same. And I thought about it and was like, yeah, you're right. I mean, really, for this 40 pounds, I either need to do a pound a cure and stick to it, and, or, you know, I need to figure it out without having a revision. But for people who don't feel that way, or, you know, were, you know, maybe, I mean, I know someone who was 600 pounds and they did VSG as a precursor to a DS. And then, I mean, she lost like 300 pounds and she's okay with it. But if you still have 100 pounds to lose, or, I mean, when would you consider going and talking about a revision?
Well, you know, the situation would really be the same as if you hadn't had surgery at all. So, you know, when do you consider weight loss surgery? When your comorbid conditions are threatening your health, when your weight is impacting your quality of life, your mobility, all of these things that kind of go into someone choosing to have weight loss surgery in the first place should really be kind of the same criteria you use for revision. The caveat to that, though, is that you have to recognize that revision is not as effective as primary weight loss surgery. So when you're lining up risks and benefits, and especially if you're talking about, say, revision from a sleeve to a duodenal switch. A duodenal switch is a pretty heavy operation. You know, there's a lot going on there. There's a lot of risks. And the lifetime sequelae in terms of vitamin deficiencies and malabsorption, those are very real. People talk about that a lot with the gastric bypass, but they don't experience them a lot. With the duodenal switch, this is kind of part of life. So all of a sudden, we're choosing a higher risk surgery, and the benefits are a little lower, so that the decision oftentimes becomes much more complicated and difficult. You know, you're 400 pounds, you want to have a Roux-en-Y by a competent surgeon, you have maybe a 2% serious complication rate. That, and you know, versus the factors that go into weighing 400 pounds, that's a very easy decision, quite frankly. You know, and even if you're in that 2% serious complications, it doesn't mean you die. It just means things suck for a month or two.
Right.
That's easy. You're at 250 and you want to have a duodenal switch, which will only get you to say 180 maybe. And now you've got all the issues related to the duodenal switch. That's harder. The scales don't tip so dramatically with revision surgery.
Right. Can you talk a little bit just because some people in the weight loss surgery community, like on YouTube and Instagram, have had distal bypass. Can you talk a little bit about what that is?
So distal bypass is essentially a gastric bypass where you make the limbs longer. So every surgeon, what I found is that almost no two surgeons make their limbs exactly the same length. I make one of the limbs 60 centimeters, which is 2 feet, and the other limb 150 centimeters, which is 5 feet, but it's not, we don't take a ruler in there, you know, I kind of say, that's about 10 centimeters. And, you know, I can count 15 times those 10 centimeters, and that's my 150 centimeter ruler. When I watch other surgeons do it, I think, his 10s are bigger than my 10s, or his 10s are smaller than my 10s, and he may go 120 and 50. So there's no standardization, but we're all pretty close. A distal gastric bypass is where you either go much longer, or very often, instead of we're going forward counting, and people have variable lengths of intestines. Some people have 15 feet, some people have 25 feet, you know, depending on how tall you are and how you were made and everything like that. A distal gastric bypass, often you'll go to the very end and count backward, which is really the important measure. You want to say, how much intestine are you going to have left to do the absorption? Because the bypass separates the food from the enzymes, and there's no absorption when they're separate. It's only when they come together that you can absorb. So a distal gastric bypass will go 150 centimeters, 200 centimeters, sometimes even 100 centimeters from the end back, which tends to be much more malabsorptive. So what do you get from a distal gastric bypass? Well, you definitely get more vitamin deficiencies. You definitely get some protein malnutrition. Do you get more weight loss? It turns out not that much. Maybe 10% more, 5% more. So my opinion on distal gastric bypass is you're typically buying yourself a lot of problems for a modest amount of weight loss.
Okay, that's interesting. I just want to check these questions real quick to see if
Sure.
someone says that they love you and watch all your videos before. That's Sadie's Travels. Watch all your videos before surgery and have helped her be tremendously successful 3 years out. So
congratulations.
Thank you. Okay, here's a question from M. Lewis, and this is what I hear all the time, and I roll my eyes a little bit because I just don't think it's true. Talk to me about stretching your sleeve and your pouch and all that stuff.
So, this idea that it's some anatomical stretching, I think is really founded in our misunderstanding of obesity. And there's also some degree of prejudice against it, because the implication of stretching is that you stretched it. You couldn't control your eating. You overate. You have no self-control, and you stretched it out, and now it doesn't work anymore. And again, this gets back to this whole societal thought process we have, which is that obesity is the fault of the person who has the disease. If someone were to go into the emergency room, and even if they were, let's say, a heavy smoker and ate nothing but, saturated fat all day long and never went to see the doctor and was in the midst of a terrible heart attack, and the ER doctor turned to them and said, "See this? This is what happens when you smoke and you eat terribly. Sucks to be you." We would look at that doctor as the most heartless, cruel person that should lose their medical license. However, everyone who's struggling with obesity can attest to at least one time when a physician shamed them for their weight and blamed them for their weight. So this whole concept of stretching kind of still, to me, it's an expansion of that whole idea that this is just a lack of self-control. And even with this weight loss surgery, you stretched it. But it really points to anatomic changes as the driving factor of weight loss. When what we're recognizing is it's not the anatomic changes. Making the sleeve more narrow causes more complications, but not necessarily more weight loss. Making pouches slightly larger, slightly smaller, making the opening bigger or smaller, again, causes more issues, but doesn't necessarily drive more weight loss. And the reason is it's the hormonal shifts. It's the ghrelin, the leptin, all of the other proteins and hormones and nerve signals that we don't really understand that well that are driving the weight loss. So, I have a video on YouTube about stretching your stomach out. And it's kind of like a clickbait type video, because it's like, how do I prevent my stomach from stretching out? And the answer is, well, it's not really that. It's that your eating behaviors may have fallen off. You may have fallen, victim to some of the hidden causes of obesity. It's more than that.
Yeah. Couple more questions. Susie VSG wants to know. Well, first she says you are hands down the best, most compassionate bariatric surgeon that she's come in contact with.
Oh, thank you.
I don't think she watched your videos. I was like, I know her. I don't think she was your patient, but yeah, way better than the interview I did with Dr. Vong. Let's just say that. But Susie also asked, why is it necessary for VSG patients to take supplements post weight loss surgery? Just generally.
That's a great question, Susie. Why? Dogma. This is what we do. This is what we've always done. Now, that being said, most sleeve patients probably don't really require long-term vitamin supplementation. The problem is that there is a subset of people who do. And until we figure out where you are, how you're going to do, we're potentially setting people up for some terrible complications if we just say, oh, you're asleep, forget about it. And there's two issues that we have to worry about in terms of vitamin supplementation for sleeve patients. The first is iron, just like with the gastric bypass. and you can become anemic. You're more susceptible to anemia. It's a very complicated mechanism that I won't go into, but truthfully, the more weight you lose after a sleeve, probably the more susceptible you are to anemia. So you got to have that checked. You got to take a bariatric iron, not ferrous sulfate. Sleeve patients probably could tolerate ferrous sulfate, but still, I think the chelated iron, like what you get from the bariatric iron supplements, is a far superior product because it's better tolerated. It doesn't cause constipation or abdominal cramping. So the second, and I think the worst vitamin deficiencies I've ever seen, I've seen this twice in my career, is a thiamine deficiency, and I've seen them both in sleeve patients. There are some characteristics of patients who are susceptible to it. The number one cause of chronic thiamine deficiency is frequent vomiting. And you put a bunch of sleeve patients together and ask them about vomiting, and you're going to get answers all over the map. I have never vomited since my surgery, some people will say. Other people will say, I vomit every day. And you'll get a range in between. The patients who vomit every day are at significant risk for thiamine deficiency. Lower socioeconomic class also puts patients at risk for thiamine deficiency. I think because their diet hasn't had a lot of fruits and vegetables and other foods that contain thiamine in them. And so they may have kind of depleted stores, and then they have this period where they're really not able to tolerate anything. And they become thiamine deficient. And then finally, non-compliance, of course, with your vitamin supplements. That's a risk factor for that as well. But thiamine deficiency can cause permanent brain damage.
Yeah, I watched a YouTube channel chain of someone who had weight loss surgery and had that. It's awful.
It's terrible.
So, I was going to say, I've heard of a lot of VSG patients recently who've talked about iron deficiencies, iron infusions. And I feel like I'm relatively well informed, and I was not aware that I should be taking a bariatric iron supplement. So
you may not need to. You should have your iron checked. If you're
no, I do, but I just didn't even know that was a thing, or that I should be thinking about that.
Probably 5 to 10% of sleeve patients have issues with iron.
Okay.
25, 30% for bypass.
And beautiful Alicia is here. She's someone who did have a distal bypass and with a micro pouch, and she says it's been life-changing. So that's awesome. And Esther is here. Okay, so we talked about anything else about revisions you want to mention before I just get into like regain and what to do about it?
The thing about revisions is, I think you got to realize it's 10 times the risk and half the benefit. Right. And I think go into it with that approach, and you'll make a good decision.
Right. And that's, I mean, although sometimes it's tempting for me to consider it and to think about it, that's what I think. It's like, I've always been very healthy, and, and I put off weight loss surgery for, probably 20 years, probably from the very first time I went and got a consultant, because I was a single mom. My son was at home. I was worried about, all these complications you see. At least back in the day, I don't see it anymore. And maybe it's because most of the people I know have weight loss surgery are, through a community that's pretty invested in their health.
Sure.
I could look at somebody and say, oh, that person obviously had weight loss surgery. I mean, they look unhealthy. They look, what does that come from? I just sort of assumed it was like not eating a lot of protein or.
My thought, first of all, if someone's super successful and loses a lot of weight rapidly, they often will kind of look a little cachexic, and, you can tell. I think as we are encouraging more and more weight loss surgery patients to not necessarily live on protein shakes and low carb meals, and instead encouraging more of a whole foods, fruit, vegetable, nuts, seeds, beans approach to eating, that we're going to see less and less of that. But I think that, it depends on your timing too. In that first year, sometimes people can look like that. I think one more comment on revisions too is, if you do have bad acid reflux, revision to a gastric bypass is life-changing. Yeah. It works. It works every time. It's not a terrible surgery. And if you're really struggling with that, you should strongly consider it, because it will end the problem.
Yeah. So I have to figure out how to help my friend get that taken care of, because I mean, it is really impacting.
Yeah. Just don't use the word bariatric.
Right.
Tell them not to. I have acid reflux.
Okay. And All right. So let's talk about, well, okay, you brought up, a whole foods approach. So I think everybody has, one of the things that I get a little not annoyed with, but it just makes me sad that I'm seeing all these people who are, 3, 4, 5 years post-op back on the bandwagon of every single diet known to man, of taking diet pills, of keto, which I have done and works well for me, but is not a lifetime solution. And I just gained the weight right back. Going back to Weight Watchers, which there's nothing wrong with any of that, but it just makes me so sad that we're going back to the same thing that we've always done that never worked.
Yeah. I think nutrition, we have to start looking at nutrition more like we look at religion. To some degree, religion is something you can never prove, and often something you can never convince someone else of. There are always these people who are like, 1 week they're a Buddhist, then they're looking at the Kabbalah, and it's like they're constantly on this kind of religious exploration, and it's clear they're looking for something that they have not found. Then there's other people who have kind of been, involved in their faith and are observant and believe in it and find a lot of solace and comfort in that. And they're not at all interested in changing. And they just want to kind of be able to practice that religion. I think we have to start looking at nutrition that way. Even if that person who's practicing that religion has something terrible happen in their life, they'll still turn to their religion. They'll still, use religion. Oh, God must have had a reason for taking my husband from me. It's just this kind of unshakable foundation. And I really encourage weight loss surgery patients to kind of take that same approach to nutrition. I've done my research. Fads will come and go. There will be lots and lots of discussion about different diets. But I believe that the foods that were put on this planet for us to eat as cavemen are the foods that we should be eating. And that doesn't mean I'm endorsing paleo, because paleo is typically misrepresented as a eat all the meat you like. But it's the fruits and the vegetables and the nuts and the seeds and the beans and small amounts of animal protein used for celebration and flavor enhancing and kind of to make a dish special. As opposed to the backbone of the dish. So I think that approach is, to me, the one that works. It's the most grounded in reality. It's not really kind of sellable. There's, anyone who says like eat a lot of fruits and vegetables, they're not going to find themselves on the Today Show, or there's not going to be, tons and tons of social media articles about this. But it's the religion that I think works best for anyone struggling with obesity. And you have to just kind of tune out the noise and have faith in the fact that this is a very solid approach. It's not sexy, it's not cool, it's not necessarily easy, but it works and it's sensible, and it keeps you from kind of riding this roller coaster, always searching for more weight loss or better control and kind of falling victim to yo-yo dieting and restoring food addictions. And that's my thoughts on it.
So someone posted in the chat, and I do think that this is a problem for some weight loss surgery. What if you have a hard time eating fruits and vegetables post-weight loss?
I think a hard time, why? That's a question that needs a lot of follow-up information. So why do you have a hard time eating fruits and vegetables? Because you don't like them? Well, when I talk to people about whether they like fruits and vegetables, they'll start and say, I don't like fruits and vegetables. Well, can you name one fruit that you like? Oh, yeah, I guess I like oranges. Pineapple's not bad. Okay, so you do like fruits and vegetables. You do like some fruits. You just don't like all fruits. That's fine. So eat the fruits you like. It may be only two of them for starters. But what happens is, as you get the refined sugar and the artificial sweeteners out of your diet, and you start eating the fruit, other fruit starts to taste good too. And it's something to build and grow on. Same thing obviously applies for vegetables. There's there's always something that people like. Oh, I do like those little pea pods. Those are actually pretty good. Okay, get some pea pods. Let's start working on those. If you can't eat them because they make you throw up or you have abdominal cramping, that requires further evaluation by a physician, because that's abnormal.
Okay. Okay. Yeah, they make me sick and go right through her. So, okay. So
Yeah.
probably
So
that's
that's
fine.
something I'd want to talk to your gastroenterologist about, because it's really, if you can't tolerate fruits and vegetables, that's something, that's something going on with your GI system.
So, let's talk about some of the. So one of the things that I always say I feel is super important for people in their, and I'm not a medical professional, in their early times post weight loss surgery, is that you use that time when you're getting a lot of positive reinforcement from weight loss
Yeah.
to change your habits
Yep.
as it relates to what you eat, drinking your water, moving your body, etc. If but there's a lot of people who don't. There's a lot of people who use that time as sort of a freebie, which it is.
And
You'll lose weight and still eating crap, I mean, during that first year and a half, but I think you're at a real, it's only going to make it. I think those are the people who you see like regaining all or almost all of their weight.
they go down and then they start to go right back up.
Yeah. And it's so heartbreaking for me to see that. It's so heartbreaking. But, it happens. It's a thing. It's, I feel like I went through I don't know, I had my surgery at Kaiser. They do a 12-week program with you that has nothing whatsoever to do with bariatric surgery. The way they teach you to eat, I remember the last day of class before we were going to get surgery, I was like, well, we can't eat this, right? You're saying we're not even going to be able to get in 600 calories, but okay. But what was really helpful about that time was they said, and they sort of lied because people who didn't lose 10% of their body weight got surgery anyway. They said, you're not going to get surgery unless you lose 10% of your body weight. So I just started, and I think that was crucial to my success long term, because I got rid of my addiction to sugar and all that stuff during that phase. Yeah. Not that it doesn't occasionally come back, but I changed my habits during that time. So, but not everybody does, not everybody can. So what if you're 3 years out and you didn't use that time to change your habits and you're struggling with regain? What do you do?
You start now. It's a little harder, but it works. People follow my program who haven't had weight loss surgery and are incredibly successful.
So let's talk about what Pound to Cure and what your program is.
So first of all, I have the YouTube channel, but I've also, I like the YouTube because it's a great way to communicate with people. The problem with it is it's a lot of one-offs, like, hey, here's something interesting. Mm-hmm. And I think surgery patients really, to some degree, and I created this essentially for my own patients and have just kind of expanded it to be available for anybody. They need a structured guide, kind of like the 12 weeks you had. And, some can be good. Some of these programs can be not good. But you need a structured guide. Like let's talk about how to eat and kind of work through animal protein, vegetable protein, carbohydrate, processed carbs, fruits, vegetables, nuts, seeds. Each one kind of develop with their own topic, and they make less sexy and enjoyable YouTube videos, but I think they provide you more of a structure and a basic understanding, almost like a college course would be, versus going to attend just a single lecture. So I put that together. That's on poundofcureweightloss.com. And I've got 5 courses on nutrition and 5 courses on bariatric surgery. And the bariatric surgery courses are kind of where you are. Some of them are free, some you have to pay for. But I think those educational videos, to me, kind of give someone the structure. So if you're really looking to find out more about how to eat following the Pound to Cure, probably nutrition course number 2, which is a metabolic reset diet, will give you all of those details. But it really is just this concept that some foods will work to lower your set point, the body weight that you kind of like to center around, and other foods will cause your set point to go up. And it really is very tightly linked to nutrition density. So and I think probably Joel Fuhrman has done the best job really outlining nutrition density. There's another woman who wrote something about volumetrics, which is also very good. But the concept is you want to figure out how much nutrition you can get in the fewest number of calories. So if we take like spinach, 100 calories of spinach is 1 pound of spinach. Those huge, those are the big bags. When you go to the grocery store.
And it makes that much after you cook it.
Yeah, it makes that much after you cook it. But the smaller bags are usually around 8 ounces. It's the big bag, like the extra huge bag of spinach, the one you think, oh, I could never eat all that spinach. That's 1 pound. That's 100 calories. Think about how much nutrition is in that huge bag of spinach, a tremendous amount of nutrition. And then let's think about, candy, right? A hard candy. A small hard candy may be, 30 calories, 40 calories, and there's absolutely zero nutrition in it. Think about a Big Mac. It could be 500 calories. There's just not a lot of nutrition. It's iceberg lettuce, a few tomatoes. I mean, the meat is really poor quality. There's just very little nutrition in that large number of calories. So we have kind of two ends of the spectrum, and then most foods are going to fall somewhere in between. So it turns out that as you eat more of the nutritionally dense foods, those tend to be set point lowering foods.
So we have a conversation going on in chat that I want to bring up because I think it's really important. So Esther is saying the habits we have with food did not disappear with surgery. Mental health triggers life stressors. So I want to say, first of all, when I'm talking about habits, I'm talking about like the habits, the exercise, the way you eat, the water, whatever. However, this mental stuff really, truly has an impact. And we've spent our, whole lives using food to cope with things. And I sort of joke about, pardon my French, but my channel, they're used to me saying this, but the mental mind fuck that comes with weight loss surgery. When a friend of mine and I, who were older when we had weight loss surgery, we were watching people on YouTube and we're like, oh yeah, the mental, they have that. We're not going to have that because we're at the stage that they're at and we haven't had it. It's because we were older when we had surgery. It's because we're more mature. What I've realized is it comes when you're about a year at a semi-normal weight for about a year and you start having to deal with all the things that you pushed away or secluded yourself from without your coping mechanism, which is food. So we both had it, but because we both had so much weight to lose, it happened a little bit later than it did for other people. But it's such a huge stumbling block. What do you tell your patients in terms of dealing with the mental stuff and that you're used to using food for everything? And
so I think there's a lot going on there. And I think there's a lot of things that are to some degree controversial. My general philosophy is that being overweight will make someone crazy, but being crazy doesn't make someone overweight. And I think that's an important thing to kind of keep in mind. Many, many people use food to soothe themselves emotionally. Not all of them develop significant obesity. So, if we put this whole success thing on solving every emotional issue that you have, you're setting yourself up for failure. I mean, life is a struggle and emotional issues are just part of the deal, and they're going to be there from start to finish. And so if you kind of look at this as like, once I get this whole emotional thing settled, then I'll be able to fix my weight. That's like putting a mountain in front of the obstacle. So I really try to encourage people to kind of not necessarily overly link the two. Now, that doesn't mean that there's no link whatsoever. Not in any way am I saying, oh, there's no emotional component to obesity. There absolutely is. That's not really what I'm saying. My point is I think we tend to overrepresent it, that there's a lot going on physiologically here, and that your behaviors may not be as outlandish as you believe they are. It's just that your physiology makes these behaviors have much more of an impact on you than on others. So I think that's kind of my first approach to it. But there are definitely people who use food to kind of soothe themselves. The beauty of weight loss surgery is that it often takes the reward away. So, using food to soothe yourself is kind of a habit. So habits have triggers like stress. They have behaviors like eating, and then there's a reward. The reward is the rush of dopamine and other pleasure signals in your brain that make you feel good. And weight loss surgery kind of blocks, at least initially, blocks that effect. You don't feel as good after eating, especially with a Roux-en-Y, but sometimes with a sleeve too, for sure. you don't get that same pleasure signal. Some people, for some people it's stronger than others. There's a lot of variability there, but I think that's, you want to use that first year to kind of break that habit and start to find other things. So when I get stressed, now I put on a yoga video, now I call a friend, now I meditate, whatever. I don't care what it is. It's just something besides eating. So you want to use that to your advantage.
Yeah. And I just want to share a couple of my experiences related to that, which number one is the thing that was so fascinating to me, like immediately after surgery, was that because you're used to just feeding yourself all the time. So all of a sudden I became very aware of when I wanted to feed myself, not for nutrition.
Yeah.
And what was good about it was I couldn't at that point because it was so early post-op, but it made me aware. And I think being aware of how you're feeling in a moment and trying to unpack that a little bit instead of immediately going to food to fix it has been pretty helpful to me. And I am certainly not perfect, but that's one thing, is to look at, why are you eating?
Right.
And
that really gets to mindful eating. Right.
Exactly. And, speaking of volume, so one of the things I know about myself is, from a soothing perspective, is there is something about when I go to bed at night that I want that full feeling. There is something that's comforting. I mean, who knows where that goes back to, but whatever. And what I've started doing recently, as I am trying yet again to get off this regain, is the only thing I will really eat at night is vegetables, because they are so filling and they give me that feeling without the sugar rush and the. So
that's just a brilliant way to address that issue, right? Take a step back, identify the root of the problem, come up with an appropriate solution, put it in place, right? No emotion, no, my mother did this to me, and so now I need to feel full at night or I can't go to sleep. It's just, this is a simple problem and I've come up with a simple solution. It's very elegant. That's that's a beautiful example of how to approach problems like this.
And I can't do it all the time. This weekend I had emotional reaction, and I honestly, I was terrified. I'm like, I am in bed eating food. This reminds me of how I used to be when I was 400 pounds.
Yeah.
But the thing is, sometimes that's going to happen. And what I knew is Monday morning, I had to get up at 4:30 and go work out. And I had to reinstitute my spiritual practice. And I had to do these things that I didn't necessarily want to do. But I know I have those as options now.
Yeah.
And I had another thing I wanted to ask you, and now I can't remember. What about statistics on cross addiction and divorce? Because I think those are sort of overinflated. I mean, I know they happen, but what's the real scoop on that?
Okay, so divorce. Let's talk about divorce first. Here's my thoughts on weight loss surgery and your marriage. I'm not a marriage counselor, but I am married happily. And I am a weight loss surgeon, so I guess I have some say in this. Weight loss surgery makes bad marriages end and good marriages better. That's been my experience. And I can oftentimes, just in the initial consult, when I'm seeing the interactions between the husband and the wife, sometimes the husband is like, babe, I got you. Whatever you need to do to be happy, I'm there for you. They're going to do great. They're not going to get divorced. The other times when the husband's like, but you do eat this and you do eat that, and you ate potato chips last night, that lady is looking for a way that she can get out of this terrible body, which she feels is keeping her trapped with this terrible person. And those marriages, quite frankly, when they end, that's not necessarily a bad thing, and I think that's not a bad outcome.
Yeah, Tom Cruise. We have a guy here. That's awesome. Tom Cruise is in here, and he says that it makes medium marriages more medium.
It's probably true.
Yeah, one of the things, I honestly feel fortunate that I was single during this process, because I have to tell you, I really feel for weight loss surgery husbands, because they're sort of, in a, they're sort of in a quandary a little bit, because it's like, everybody's telling your wife she looks amazing. You're afraid if you say that, she's going to think you didn't love her before.
Yeah.
And if you don't say it, she's going to be like, I mean, I just really feel for some of the weight loss surgery husbands out there.
Listen, communication is key, and
it's hard. I mean,
not just what you say, it's how you say it. And
yeah. What about alcoholism?
So let's talk about transfer addictions and alcoholism. So I think, initially, again, because we kind of looked at obese people as these food addicts, not recognizing that there's a significant percentage of patients who are very overweight, who don't eat that terribly, but really just have had life experiences and physiology that have driven this obesity. We've always looked at it like, oh, this person must be a food addict. And therefore, once we take away their ability to eat food, they turn to something else because they're just an addict by nature. But they're not an addict by nature. They're not a gambler. They weren't an alcoholic before surgery. They never really did any drugs. They were a non-smoker. They don't, exhibit addictive behaviors in any other component of their life. It's because their obesity is not the result of food addiction either. It's a result of physiology. So again, we kind of misunderstood it, and then we therefore believed in blaming the patient that this transfer addiction was therefore their newfound outlet for their addictive behavior, when that's really not what's going on. So alcoholism is the number one long-term complication after gastric bypass surgery, in my opinion.
Wow.
The number one worst, not the highest, but the worst. Iron deficiency is the highest. Alcoholism is probably the second highest. Marginal ulcers and bowel obstructions are probably just a little bit below alcoholism. Somewhere, I would say 4%. I see some numbers up to 6-8%, and I believe them. I think there's something there. I think it's all about how you measure it. If you drink more than before, it's going to be high. If it's, you're a total alcoholic, going to the meetings every week, then it's probably a little lower. But this is not an emotional thing. This is a physiologic thing. And I think that's something, that's always my take as a physician. There's so much going on physiologically, and I think, over-emotionalize obesity, over-emotionalize bariatric surgery. Not that emotions aren't important, don't get me wrong, but it's just that we tie so much self-blame and self-loathing to problems that are driven by our physiology and are to some degree beyond our control. So kind of a little side note, but alcohol after a gastric bypass is absorbed differently. You absorb it faster, you get drunk often longer. It takes less alcohol to get you drunk. Some people actually don't like alcohol at all after gastric bypass surgery. I don't worry about them. Some people, this is a new drug, and this new drug triggers certain centers in their brain, which causes them to develop alcoholism. And it's real. It's something that I talk to every preoperative gastric bypass patient about. And we see it after sleep, don't get me wrong. It's just not nearly as pronounced, and the differences are not nearly as strong as we see with the gastric bypass. And patients who have had heavy alcohol use before surgery, and in the literature, heavy is defined as more than 2 drinks per week.
Whoa.
That's a lot of alcohol.
Wow.
Right?
Right.
Yeah. It doesn't take a lot of alcohol to put you at risk for having alcoholism. So if you are a heavy user, especially kind of a daily user of alcohol, you're at significant risk for developing alcoholism after a gastric bypass. And I think if you're considering that surgery, you really have to be willing to opt for complete and total sobriety if you start to notice that you like alcohol more. My general rule of thumb is you cannot drink more after surgery than you did before.
Well, I think there are lots of us who drink more after surgery than we did before.
And, beyond the weight regain component of that, because a lot of alcohol, first of all, cocktails are in sugar sweetened beverages, which are, the worst thing. White wine is to some degree a sugar sweetened beverage. And even red wine, which is good and probably your best option, it's not like you're immune from weight gain from drinking red wine.
Right.
So there's that element of it too. But I think that's something to be very cognizant of. And, alcohol use disorders are a spectrum. On one hand, you got kind of the skid row drunk. On the other hand, you have the person who just is a total teetotaler. And most of us fall somewhere in between that range. And, you know, if you're here, you use a little bit of alcohol, it's not that big of a deal. You may go to here where all of a sudden it starts interfering with relationships and professional, you know, satisfaction, causing depression, your own, you know, you're going to move oftentimes. And where you move is it can be to a not a better place.
Yeah. Yeah. I can't believe this hour's gone by so fast, and I have two more things I want to ask you.
Okay.
So really quickly, and this is another personal question. My father's a physician. He's 75 years old and has always struggled with his weight. His doctor just referred him for a bariatric consult, which he is a little resistant to, which I've wanted him to do since I did it. What's your thoughts on people who are that age having bariatric surgery?
So I've operated, I think 76 is the oldest I've operated on. I do sleeves as people get older. I don't really offer gastric bypasses. It's just too much. You know, again, the biggest problem with sleeves is weight regain. You're 75, 76 years old. You're just not going to be alive long enough, quite frankly. And even if you do live another 20 years, our kind of period of life where we can gain weight tends to end somewhere in our mid 70s.
Oh, interesting.
So it's just not a lot of potential for gaining weight as you age. As you get older and older, it gets harder and harder to gain weight. And typically what happens is as you live your life, you gain weight over time. And then once you start to get old, then sometimes your weight goes down a little bit. So I think that it has to be, again, it's risks, benefits, right? You're older, the risks are less because you're going to, you have less years to enjoy the quality of life. The risks are higher because you're older and have more medical problems. But sleeves are so safe for the most part, you can usually still get the scales to tip in your favor. So, assuming he's a good operative risk, I think it's probably a very good thing. And you can preserve your mobility longer, and it can actually be pretty life-changing even for people in that age range.
Yeah, and he's a still working ER doc who's on his feet all day.
Wow.
So, yeah. Okay. And then the one thing we talked about before we got on that we didn't touch base on that I think is really important is hidden factors of regain. Things you might not
so we have just a few minutes to cover that. But
right.
I think there's so many things beyond food that cause weight regain. And it's really critical that we're all aware of those. Number one, medications. There's a lot of medications that cause weight gain. Trazodone, which is often used for sleep, Depo-Provera for pregnancy, for birth control, a lot of bipolar medications. There's this new Abilify, which is a second-line depression medication. So it's being used on a lot of patients who are on an SSRI like Prozac or Paxil and who are still having symptoms, and they're prescribed Abilify, which can cause a tremendous amount of weight gain. So there's a growing number of medications out there that cause a substantial amount of weight gain.
I think I know. I take Trazodone, and I did not know that for sleep.
Yep.
Interesting. Okay.
Yeah, Trazodone causes a lot of weight gain. Wow. It's very common. Since moving to Tucson, in Arizona, it's like everybody's on Trazodone. You know, it's like just whatever. There just tends to be kind of cultural practices. In Michigan, I'd see it, but not a ton. Here in Arizona, it seems like every other patient takes Trazodone for sleep.
What do you recommend that's not like a... I mean, no, I don't want to Ambien. I don't want to Ambien.
Yeah, Ambien makes you a little crazy. Benadryl, melatonin, meditation, relaxation tapes.
Wow. I guess because you know what, this last little bit of regain has been associated to when I started taking Trazodone. That's fascinating to me.
There you go.
Okay, so I think we're on time. But any other quick?
And the other people tend to be a little more aware of inactivity and injury, chronic stress and depression, sleep disturbances, which kind of gets a little.
Somebody talked about that. The question, and I forgot to ask it. Sleep. What's the impact of not getting a lot of sleep?
Working the night shift makes you gain weight. When your sleep-wake cycle does not follow the normal daylight, nighttime pattern, that for some reason causes weight gain. So there's others too. If you go to course number 1 on Pound of Cure weight loss, I list all of those hidden causes as things that cause your set point to go up. And there's a video kind of on each one of those items outlining those. And I think that's a free course. So it's nutrition course number 1 on poundofcureweightloss.com that will go over all of those.
Okay, awesome. And you're working on a book. What's your new
I'm
book?
working on a book. The book's done. I just have to edit it. But, you know, moving to Arizona has been extremely time consuming. Getting set up with a new practice, kind of making everything happen has been time consuming. But I'm going to get it out.
Okay, so when it's out, will you come back? Because you're amazing.
For sure. Thank you so much for having me. You're amazing too, Liz. Congratulations on your success. You're doing amazing. You're really doing great. Just keep doing what you're doing. It's a struggle. There's no end point where you get to relax, but you're fighting the good fight every day, and I applaud you for that.
Thank you. All right, guys, thanks for joining us today. And hopefully, because I could go on for hours with this man, so hopefully he'll come back again, and I will talk to you guys later.
All right. Take